So the course agenda for today is we're going to talk about the overview, which will have the anatomy, the concepts behind why we are doing it, and where should we be putting all these threads. So the levels and everything, we will talk about that. Then we are using 3 different products, so we'll talk about that. We'll talk about the procedural details, some other adjunctive procedures that you can add, we'll just name it, some complications, which is very important, what not to do or how to handle those complications, some before and afters. Some of them are my patients and some of them are somebody else's patients. And then we're going to do the live hand cases, and just to, if we have got time, which we will go through some what you call is the intravascular complications, how to avoid it, not how to treat it, but how to avoid it, and we're going to talk about that. Right. Erythium dorsatum, with porcupine, it has got these quills, and these quills have got these small little spikes, and what it does is basically it, against its enemies, it just let this spike or this quill go, and it gets stuck to the skin, and it's very difficult to remove it. So this was the concept behind the first what you call it barb sutures or the cogs. These are presently, as of now, these are 3 different types of threads in the market. The one is the Aptos, which is the first one who started the cogs. Initially it was unidirectional, and now they are bidirectional. Initially all these threads were actually non-absorbable, and now they are absorbable. Similarly, and that was in early 1990s. Then we went to silhouette threads. Silhouette threads initially was again silhouette lift, which means you will anchor at one place and you will lift in one direction, right? And later on, with all the dermatologists and everything, what happened, the silhouette soft, because the surgery, a lot of people who do not have the concept of surgical thing, so they wanted something which does not involve in surgery, so it came out as a bidirectional cones as well. Now, when we talk about facial aging, we need to understand why the face is aged. Is it the skin? Is it the subcutaneous tissue? It is the fat pads, or is it the bone? The latest part of it is that when your bone, let's say if this bone gets smaller, this septum, orbital septum protrudes and everything hangs down. So what you do is that you actually, this area has hang down because this bone has gone back. So if it is not that much and the person is youngish, all you have to do is put a little filler over there, and that is where it started with the liquid facelift. It was not facelifting, it was reconstruction of the structure. So once you reconstruct the structure, the envelope automatically adjusts itself. When we are doing all these things, you need to understand all the facial muscles that work. So just imagine if I'm putting anything on top of this muscle, it will move with the muscle. If I'm putting on the bone, muscle will move with it. The reason being why the muscle and skin will move is because there are certain ligaments attached to it, right? And these are true ligaments and these are false ligaments. The true ligaments goes from the bone to the skin, and the false ligaments go from the fascia to the skin. And we're going to discuss that thing. You need to understand about your nerves, which is facial nerves, motor nerves, because this can be injured. And that are one of the complications. It's a very rare complication, and total neurotomesis is not there, but neuropraxia is there. So it's usually resolved within 6 weeks, 3 months, or something like that. There are certain danger zones where these nerves are really superficial, or where you have to be a little bit careful. So all you have to do is you need to understand this mandibular branch, this facial branch or temporal branch of the facial nerve. So these are the two most superficial ones. So you need to understand where it is. Right. Now, these are different layers of the skin on the face, and these are different. Important things are these are different. You can see the adhesions between the bone. Septae could be adhesions, could be true ligaments, and could be other mandibular ligament, which is not actually a true ligament, which is a basically it's false. Now these are sorry, mandibular is true ligament as well. So what happens is you can see that this ligament, which is actually the mesenteric ligament, and above that is the parotid ligament. It is parotid cutaneous, going from the parotid fascia to the cutaneous, and then the mandibular ligament where you get this jowls, right? So what you do is you have to pull these places in order to lift the skin, in order to make sure you put them back over there. This is where you will get some bunching around. Now, when we do anything, we need to understand what is the severity, because the severity of the case will help you to decide the type of treatment. If there is no visible fold, of course you don't want to do anything. If it is, let's say, mild or shallow, rather than going for the threads, you can go for the fillers, because threads are slightly expensive than the fillers. And sometimes with that small little things, you might not be able to really see the impact of the threads if you have got very initial stages. I would generally 4 or 5 or maybe touching the upper part of the 3, that is where I would give an option of threads. Thread is not a replacement of facelift, but threads can be used for the patients who do not want to have a facelift. Right? It is not a substitute for a facelift. Surgery is surgery. But if the patient doesn't want, you can give this option to them. And there are other ways of doing the wrinkle scale or marionette line scale. Now, once you know what are the different problems, you can correct that thing and then you can gauge them. So these are global aesthetic improvement scales, which will help you. It's a very subjective, but it is a way of bringing subjective analysis into an objective analysis, because you want to have a standard of objective analysis. So whether it's a worse, the appearance is worse than the original conditions, there is no change, it's just obvious improvement. Obvious improvement, if you can feel it, it's about 15 or 20%. If you can see it, is about 25%, right? Then much improved means around 50% or 40%. And if you have got very much improved, that usually comes to about 50 to 60%, right? There is nothing as 100%. So again, what vectors? Vectors is very important, because how you want to lift, which direction do you want to lift is an important. Your muscles are moving constantly in the line of pull, and you can see that the vectors keeps on changing, right? Now, these vectors of muscles are important, but skin lifting might not follow these principles. For example, if you have got these muscles, it is going almost horizontally. You don't want to have a horizontal thing over here. You want to have, let's say, this is one side and this is the other one, right? So you want to lift it more vertical over here. You want to lift it more horizontal or oblique. Similarly, on the upper face, you don't want to lift vertically. You want to lift horizontally, right? So you need to understand where the muscle is, what's its pull like, but you need to understand how do you want to put the vectors in order to correct everything. Because your facial tightness is not only because of the pull, it is also the collagen, the firmness of the skin, the dermis, and all those things. So that is also important. So as you go more towards the eye, your angle of pull becomes more oblique. As you go more towards the jowl, your angle of pull becomes more vertical, right? So when we are doing surgery, a facelift, we can either pull like this or we can pull like that, right? So if we are doing it, we can do it a sort of pull over there so that this area becomes flat, or we can do a pull over here so then we can create the jowls. So that is very important. So you need to understand how to pull it. When we talk about the facelift, we basically do 4 different types of facelifts. It could be the first one where we are doing only the subcutaneous, right? This is a subcutaneous plane. You can see the ligament from bone to the fascia going towards the skin. So we are cutting the ligament between the fascia and the skin in the subcutaneous plane, and we are lifting only the skin. The other ones is the subcutaneous and subsmass. Subsmass is that fascia. So we are cutting above and below, and we are moving 2 planes in either different directions or in the same directions. Then deep plane, that means the fascia and the skin is intact. So if I pull the rug, I can pull these sofas, right? But the second one is like you are pulling the bed sheet and you are pulling the bed cover. So let's say I'm pulling the bed sheet like this and I'm pulling the bed cover like that. So you can have 2 different planes in order to adjust yourself. That's the advantage of when you are going towards both layers. And then it could be a subcutaneous plane with the smash plication. That means if you are worried about going beneath the smash where the parotid fascia, where the nerves and muscles could be, then you go above this, but instead of cutting it out, you stitch it or you sort of plicate it, right? So that is what it is. And then you can actually move the whole space, which we know it's like a tree and its branches. So you are moving the whole of it on one side. So once we know what is the problem, once we know how to adjust the problem, then we need to understand what areas can we correct with what tools, right? So today, as we are talking about threads, the areas that you want to improve with the threads is perioral lines, nasolabial folds, marionette lines, chin, jawline, and neck. You can technically put the threads anywhere in the body, whether it's thighs, arms, breast, tummy, anywhere you can do it, right? People have done it, but in our part of the world, it becomes financially not viable because these are all dissolvable things, right? Now, if we go through the threads evolution, as I said, the first one was Aptos, which started with the barbs. So we call it the first generation, right? The second generation is always smarter than the first generation. Our children will always be smarter than us, and their children would be always smarter than them, because they see the new things which are evolving. So the second, there was a limitation. It was mainly for the skin only, right? We also want to have a little bit of repositioning of the fat as well, because if remember, we are not cutting anything. So if I'm pulling the skin, the fat and the ligaments are being in the same place because of the fascia or of the bone. So it is staying at the same place, right? So what happens with the cones? Assalamu alaikum. With the cones, Dr. Sabha, idhar aa jaye. You can come here. Ye aagi jagah hai. And with the cones, which is the second generation, now what we were doing, we were pulling the soft tissue, which is the fat. So we were pulling on it. So what is happening now? I am reducing the burden of the skin from the fascia, or from that, or you know, the fascial pull, which is because fascia is at the same place. So I am pulling this fat and I'm repositioning the fat. So if there is a depression over here, nasojugal groove, and I'm pushing it, the fat over here, then I'll bring it over here to make that mount, which I want to create with the filler. So now I'm repositioning it with the second generation. The problem with the second generation was that now it is not really addressing the weight of the skin, right? So that is why one of the problems were there. So what I did was, about 2 or 3 years back, I combined them and I called them and published it as a dual plane thread lift. That means with the aptos, that means my children or myself, I was pulling the skin. I asked my children to pull the fat. Now the skin and the fat are pulled in the same direction. So the burden is lessened on every cone or every cog. So it will give me better definition of the underlying bone, and it will give me about 20% improvement in the longevity of the results, right? So about 2 years back, I came across, in one of the stalls, I came across this mesh thing. Being a surgeon, I know that if I am repairing any hernia or anything, if it is difficult, I put a mesh over there. And what happens in the mesh? The tissue goes through the mesh, and it's totally, these meshes are non-dissolvable, right? So it stays there. This mesh is dissolvable, right? Now all these ones presently in the market are dissolvable threads. So that means whether it is PLLA, polycaprolactone, or PDOs, they will all dissolve in 2 to 3 months time. So how can we get a result of 1 year to 1.5 years by a thread that will go away in 3 months, right? Have you ever thought of that? No. Maybe what happens, it's a foreign body. So there is a fibrous tissue which forms this network around it. And fibrous tissue as a scar tissue, right? Type 3 scar tissue, what it does, it softens up in about 18 months, maximum 18 months. So that is why your results do not last more than 18 months. They usually last between 9 months to, depending on how fine or how thick is that fibrous tissue. Now, if it is cones, you don't have that much of fibrous tissue. Sorry, cogs. If you have cones, you can see this cone. When you see this cone, you can see the fibrous tissue around the thread, and you can see fibrous tissue going through this cone. Now this is one connection, and you have got cones inside fibrous tissue. You need to have at least 1 millimeter of pore for the fibrous tissue to cross through it, otherwise it will bridge it. So that is why the cones last slightly longer, because of those ones, they are slightly bit thicker sort of fibrous tissue. So the same concept, when we are doing this thing, just imagine all the fibrous tissue going through that thick mesh. It's not thick mesh as it's done, but it's thicker than the actually core of it. So you have a little bit thicker fibrous tissue, so it takes longer time for it to soften up. And that is why the results are longer lasting, and it has got stronger pull, because now you can go in the fat, and within the fat or close to the fascia, all this fibrous tissue is pulling, so it's much stronger. So this is the third generation, the grandchildren. As I said, what is important? Important in any thread lift is the anchorage, which is fixation. Now we are talking about free floating. So there is one part of it is anchorage and the other part of it is pull, or maybe both are anchorage or both are pull, right? Then it is the tensile strength of the thread itself. And then it is the holding power. So if we are talking about cogs, it hardly holds 1 or 2 pounds of pressure. So the moment you do that thing, you can feel a click in it. cones will have a little bit more. Between every cone will take about 5 or 10 pounds. So if you are putting more than that, you will slip it. And that is how we are moving the other way direction. You know, sometimes you see the dimple, you push it back, you feel a click. It's a little bit bigger click. So that is what you do when you are doing that thing. And then of course, where you are putting it and the holding power. So as of now, what our patients want, this is what I said. When my patient come to me and say, I want to have this thing corrected, I want to have this thing corrected or this thing corrected. Now this and this thing is Botox. These are animated features. But at the same time, if it's a fine line and there is a little depression over here, so that means the table has gone down. If I fill it, it will relax the muscle, because as the table is going small, this muscle is compensating for it, so it becomes little bit, it's try to compensate for it. If you have got a saggy brow, you have got a hyperactive frontalis, so that is why you get these things. So you are always like this because you want to lift this eyelid, upper eyelid, so automatically your body is adjusting that subconsciously, right? So if you've got little depression, that is where this thing, Botox, filler, mainly Botox, filler as an adjunct to the Botox, not vice versa. When you are talking about this thing or that thing, pointing wing, this is mainly fillers, because that's a depression and I want to fill it up. Then when I'm talking about, Dr. Saab, this is what I want. Now that straight away becomes lift. When it becomes lift, you have got two options. Number one option is you can do, I'm talking about stage 3 sort of thing, not initially, because initially you can do a little bit of filler over here, little bit of filler over here, little bit of filler over here, and you can actually recreate that jawline, but at the expense of broadening the jaw or making your frame a little bigger. Now, some people like me wouldn't like to have a bigger frame because I'm already an extra large frame, right? So you want to make sure what you are doing it. So once I do this thing, you have got two options, either the non-surgical lift, which is thread lifts, or the surgical lift. If you are surgeon, I'm a surgeon, I would offer surgical lift without any problem. Now, that is where we comes to the first generation, COGS. COGS mainly work in the subdermal area. It can also work near the fascia, but not deep to the fascia. So what it does is, you just put underneath the skin and you can pull it, right? And that is why some of the complications were more specific to the COGS rather than to the cones. They were like dimpling and everything was more specific to this, right? And how, now let's suppose, again, if we go to that, what sort of vectors do you want to pull? You can use anything. You can use straight lines, you can use curved lines. Let's suppose if I want to pull this jowl, either I can do it like this, straight up, or I can put it like this, go like this and come up like that. So what I'll do is that I'll go in straight by pulling this up, go straight over here. When I push it down, it automatically goes like this. So these threads or the fibrous tissue, when it is formed, it tries to create a straighter line, so it will lift this thing up. When you tighten up, it will lift this thing up. So you can technically use any vector pull the way you want. You can be innovative. There is no one way of correcting it. You go to any conference, 3 doctors over there, all of them are using different one. That means one thing. That means there is no one way of doing it. There is no perfect way of doing it. The only way is you can innovate your own way. So when you are doing a procedure, you need to keep on thinking what I'm doing. You can also do this thing. So now let's suppose if we are doing this one, the top one, see how it is. Now this pull will bring back the nasolabial fold like this, right? So you want to understand that thing. And if I'm poor, this is what I was mentioning about. If you want to do this lower one and the top one is bringing the nasolabial and marionette line out, and the lower one is bringing the jowls up. So you can do anything you want as far as you understand the concepts behind it. So conceptual understanding is the most important. Right. Now, okay, fine. Some of these slides are from the time when there was more of unidirectional, so you were fixing it over here, or when you have got longer bidirectional where you go from the top or less mobile. Even now, some of these bidirectional, one of the head is going into the more fixed area, so that is less mobile, this is more mobile, right? So this will hold it and this will pull it. When we are doing cones, one of them is going up and the other one is doing this, right? So that is what it is. And these were mainly, you see, it's coming from top down, so this is less mobile, this is more mobile. Sorry. But you can do anything. You see, this is more of again lesser mobile to a more mobile, and you can see the area that you are lifting the mandibular, you are lifting the parotid, you are lifting the maxillary, all of them you are going through that. So there is no one way of doing it. That means you can keep on doing innovations, and once you do this area needs to be pulled like this in order to create a better jawline.
The cogs?
This is presently all cogs. This is presently all cogs, right? But they are different. Let's say these slides over the last 1.5 decades since I've been doing it, these slides are from different what you call it, the makers or manufacturers. So they have got their own ones, and I've tried almost every type of threads available in the market, right? So for me, it really doesn't matter. All cogs are cogs, right? All cones are cones. The concept behind it, why you are using cogs, a cog can have a spiral, it can have a straight line. The spiral ones is like this. So when you are deploying the cogs, you can go zigzag, because if I'm going zigzag like this, I'm catching more of a dermis, because I want to have as many cogs engaged as possible. Right? It's like, you know, that Gulliver, where more of those, you know, small people or dwarfs, they were more of them were actually, you know, sort of doing that thing. Anyway, you can use anything you want as far as your, they have created a mesh sort of thing with the cogs. This is like a Roman shoelace for the, what you call it, the chin and neck area. For the brow, again, if you want to lift the apex, you want to lift the lateral, you want to do the medial, you can use any type of it. So all you have to do is, do not really see what is being done. You basically need to understand the concept behind of it, and you can be the innovator. Right? You can have your own way of doing it. So when we deploy these cogs, you need to understand, in the cog we are deploying it just underneath the skin in the subcutaneous tissue, but close to the dermis. And that is why, you know, there was complications of dimpling or pull. So that was the complication specific to the product. Once you pass it, sometimes there is a little bit of bunching of the skin between these cogs, right? So all you have to do is take the same cannula or take the same needle, and you can just go between those threads, just do a little bit of you know, dissection, subcision or cannulation, and all that skin will heal quicker. And then you can do the contouring. If it is unidirectional or if it is bidirectional with two needles, like for this one over here, I've gone through the fascia, two needles coming out. Now I will sort of contour it with the cones, with cogs, with mesh, everything. You contour it. Some you contour it while you are doing it. In some you can contour it later on. Cones you can contour it later on. These cannulas, I mean, we call it PDO, but they are actually the cogs with the cannula. So sometimes you do not have the opportunity of pulling it after that. So if you have passed a cog through the cannula, the PDOs, then you have to be, you can't pull it again, because one direction of the cogs, you will actually break them. So it will become by default a unidirectional. So once you have placed, you have placed. So while the cannula is in, that is the time when you mold it. And I'll show you in a minute. So this is how I put okay, fine. I need to thank Kadri. They have given us some concession, and I'm using, in this one, I'm using his Aqualift. So these are again small little cannulas with cogs in it. So that is how, see, I'm putting it. Now see my left hand. What is this left hand doing, right? It is the intelligent hand. I'm feeling it, the depth throughout. Once I do that, now see what the hand will do. It will pull the skin this way. That, you see, can you see the pull of the hand and withdrawal of the needle? It's simultaneous. So that comes with the experience, of course. Initially, I was very conscious of doing it. Now see, it will push the skin. Have you seen that? That pull of the skin towards the fixed part is where I'm doing all that. And I'm not going to pull on these threads. I'm just going to cut them out. Can you see? It's pulling. And the last one is more vertically oriented, because, and you will see the jawline is becoming better, right? Now what I'll do is that I'll go into the neck more in line with the jawline, and I will pull it back, and you will see this skin bunching in the end, and your neck definition is coming. Now these cogs do not have that much of a grip, and it lasts hardly a year, 8 months, 1 year, 12 months, 15 months, something like that. So in the lower part of it, I'm going to lift the skin from almost this decollage area, right? That is how you can see how much wrinkling is over here, right? So all these things will resolve, right? Once we have pulled all this thing, the question is, all this skin, where does it go? It gets reabsorbed. I've pulled this skin up. I've pushed this skin, I've pushed it up. So here it goes. So what happens next? The next, that thing gets resolved. The skin has got a great tendency of rearranging itself. The collagen will rearrange itself. This is what happens, right? Just in less than 3 months, 3 weeks, sorry. So once we do that thing, there are certain things that we want to do before the operation. We want to make sure the patients do not come with NSAID medicine. We do not give them, as sometimes we have to let a little bruise be there, because the aspirin they are taking is for more important reasons. So if I'm doing the threads, I would not stop the aspirin. If I'm doing the facelift, yes, I would stop the aspirin. So it depends on what we are doing, right? And then sometimes we give sedation. Initially, I would give a little sedation because I'm apprehensive. It's my initial stages. Patient is apprehensive. So in order for the patient to be calmed down and only I be apprehensive, I'll give the patient sedation rather than taking sedation myself, right? And then, you know, if smaller treatments of about 4 threads or 5 threads or 6 threads, we really don't need to do anything. And then we have to make sure that we, when the patient comes, you ask them what they are, how they want to do it. You decide your marking and you mark things, because when you are marking, the patient is in a more of an upright position. When you are doing, the patient is lying down. So your concept of pull will change. So whatever you mark, you have to stay with those marking, and then you can inject the lidocaine with epinephrine, with or without soda bicarb. If you are adding soda bicarb, it is 9:1 ratio. And then when I'm doing cogs, I'm injecting the entire path. when I'm doing cones, I'm only injecting the entry points and the exit points, right? So this is what I'm doing. And then what you need 18 gauge needle to make the hole over there. You need towel clips to wrap things, skin hooks. Skin hooks, you really don't need it, but sometimes skin hook is important because you have to pull one area or certain area, so it helps. Scissors and you know how to hold the needle with a needle holder or with your hands. And then when you are deploying it, you must understand about the plane, which is the single most important thing. What plane are you putting your things, that thing. Make sure your cogs stay away from your gauze, because these gauze do get, you know, entangled with the cogs, and it's very difficult. I've sometimes lost a thread, and these threads are expensive, right? So then comes the post-op instruction. Now these pre and post-op instructions are more or less for all type of threads, so I'm not going to repeat that with everyone, right? Make sure the patient is not drinking with the straw. So you are not whistling, you are not doing this thing, you are not opening a big mouth so that there is not much of a stress over there. You are not sleeping on your side, you are sleeping sideways. It's a head is slightly bit propped up, and you can use some wraps or some sort of, you know, these post-surgical garments to hold it. If you use arnica, try to use it about 15 days before and about 10 days after. It helps. Dimple management will come to that thing, and pain treatment. Usually it's not painful. Sometimes if it's touching a sensory nerve, then you need to desensitize it by the area which is painful. You have to just keep on tapping that and it will get desensitized, and cold compression and everything for the swelling. So what I do is that I apply steri-strips for about 48 hours to 72 hours just for the patient to make sure that he or she is not touching that area. You can always do adjunct procedures, which could be in terms of, you know, fat transfer, fillers, or it could be, you know, lips and all those things. You can do that thing. You can do all of the non-surgical, from skin care to hair removal, and everything can be done with it. And bidirectional, you know, free floatings are like that. And then we can go to different, you know, things. If we are doing bidirectional, this is how you can improve it. Unidirectional ones with the needle which is fixed to the fascia is much more, has got much more stronger pull. And then you can have, you know, one of these for the eyebrows. You can use it. These are the double needles. You can use it for the neck. It will help for the neck. I don't know if anybody of you have tried. I've tried once or twice, but I've not done it that much, because with the fillers I'm much more comfortable, and patient, you know, usually like this. But you can actually enhance your lips with bidirectional, right? All you have to do is you have to put these threads just above the white line, which is vermilion border. You basically, what you do is that after cleaning it and numbing it, you pass this cannula. You make sure you straighten up your filter column. You pass the needle across the cannula. This is how it looks, right? Then you thread the cannula with bidirectional cogs. You can buy quill sutures, or there are certain sutures with no needles, or you can remove it from the this cogs or PDOs. You can remove it from the cannula and you can thread it over there. You make sure that the bidirectional part is in the middle, where the direction changes in the middle, and then you withdraw this needle, leaving the threads over there. Then you push on the threads, sort of bunching up, concertina effect in the middle, and it will give you this pop-up look. Sometimes it can be a little bit more enhanced, sometimes depending on how it is. Immediately you might have a little change, but it settles down and it gives you that little extra sort of effect. So this is one more tool. So this part of the cog, which is right in the middle where the direction changes, you actually put that thing right in the middle so you can do the lips. I've never used it for the nose. Being a surgeon, I do a rhinoplasty. I don't even put fillers on the nose, but yes, it can be done. You can reduce it. As in physicians, aesthetic physicians, you can always, you know, use that thing to lift the nose. Instead of doing the rhinoplasty, you can lift the skin a little bit. It can give you a nice sort of results. You can use it on the tummy, you can use it on the arms, on the thighs, on the breast and everything. So you can use all these things. Now, potential complication is when it starts showing, or when the thread is too superficial, you have to remove it. It is dimpling, you have to correct that dimpling. Now, this is one of my patients of dual plane, but you can see all those dimplings because of the cogs, right? So what I do is that I hold it and I sort of gently pull it, right? This is after about 10 days of the procedure. So I just do that thing. I hear click, click, and that's good enough. I see everything is corrected. And that is, this one was 5 minutes before this one, right? So that is how quickly you can adjust it. With the mesh, there is a problem. You have to make sure you are more accurate, because it gains the strength. This one gains the strength in about 74 days. That one gains the same strength within 12 days or 14 days. So you have to be careful. And all these dimpling, superficial, this is the transit pull. So what you do is that pull it over with the other finger. You can just simply do it that, and it will, you know, soften up. Okay. These are all complications, late complications. We are doing dimpling, asymmetry, scarring, visibility, transmitted pull, and this is where we can, you know, adjuncts in order to help it out, right? Again, the thread migration, which was mainly for the unidirectional threads, not for the bidirectional thread. As of now, most of the, if not all the threads are bidirectional. So probably the thread migration is not there until unless by pulling one side of the thread while you are placing these threads, you have already broken all the cogs. So it, by definition, it becomes a unidirectional. So it can migrate. So if it migrates, it will go from one area to other area, or because it's superficial, you feel it. Some of them are actually colored, some of them are transparent. If it is transparent, it's a little tough, a tough thing to remove this transparent one, right? But it can still be removed. Just a small little nick, take the skin hook, pull it out. You have to pull a little bit stronger and it comes out, right? Again, this is migration of the, these are old slides. Probably not, we are presently, as of now, we are probably not having those complications, right? As I said, facial nerve, you have to temporal branch, you have to understand where they are and you have to manage it so that you do not get all these problems with the facial nerve. Comes, I hope the, you were doing the first time these things. Did you understand the concept of it, right? That was cogs. Now, the same principle is with the cone. So if you know one thread, you can technically pass any thread in the world. All you need to do is understand it, right? Again, it's a bidirectional, but it's a cone. So this is what I was saying. When I'm doing the this fibrous tissue, that fibrous tissue is around this thing. Over here, the fibrous tissue goes around this thing inside that. So it becomes little stronger. It can be unidirectional, or it needs a little bit surgical part of it. So from unidirectional, we have moved to the bidirectional, where there's 4 cones on one side, 6 cones on one side, or 8 cones on one side. So it's 8 cones, 12 cones, and 16 cones of 3 different types, depending on where you are doing and who you are doing, right? So there is a, when you are doing these bidirectional, you need to understand certain principle. The important part, the engaging part of the thread is from this area to that area. Now, just remember, between each cones, or between each of these knots and the cones, you have a 5 millimeters. So if there are 4 cones, you have got about 2 centimeters. Then you have got about 1.5 centimeter in between, and then 2 centimeters. So we are talking about almost 6 centimeters of the cones and everything. So if you are putting the entry point and the exit point, you think you will move about 1 centimeter or 2 centimeters. So you have to take that distance in consideration, because otherwise one of these cones will come out of the hole. So you have got that percent less. One cone comes out, your holding power is reduced by 25%. So you need to understand what you are doing over there. So if the entire length is 6 centimeter, you have to leave 1 centimeter up and 1 centimeter down. I usually leave about 2.5 centimeters up, 2.5 centimeters down, and 6 centimeters. Almost the total length is about 10 to 11 centimeters.
So from an entry to the exit for 4 cones, you would take it up at a 6 centimeter distance?
Something like 6 centimeters, yes, 5.5 to 6 centimeters. So overall, from no, what you are seeing is what small little thing you are seeing is this small little dot.
What I'm saying is, should we leave longer than 6 for the lax skin?
Yes.
Maybe 7 centimeters?
Maybe depending on where, how much distance. Let's suppose if I've got distance like this, right? And if it is in, yes. So either what I do is, I know my 1 thread or 2 cone will come out. I can use a 6 cones one or 12 cones one. So that out of 6, if 1 comes out, I still have 5. If 2 comes out, I still have 4, right? It will cost me more, but at the end of the day, I'll have the pull. For me, pull is important, right? So that is why you need to, sometimes when you're going this thing, let's say my distance from here to here could be 8 centimeters. So not a problem, and there's a lot of movement, so I can easily do 4 or 6 cones.
My understanding is that we are marking the exit point depending upon the fat.
Yes.
I mean, where we have to keep our last cone.
Yes.
So if the last cone is at a point, then you have to keep 2 centimeters.
Yes.
Or 1.
Yes. So that when you are putting this cone over here, let's say this is the exit, and you are pulling, let's say if I know the last cone will come to this, just short of this area, so I'll pull that much of skin out so that my last cone stays in. So that overall, if I'm using 8 cones, so my 4 cones stay within the skin, they do not come out. So that is what I need to measure. So yes, you are right, we have to give that much of leverage. You can do anything you want, even with the cones, but most of the people follow this pattern. So the proximal part is the anchorage part. This is the pull part. So the proximal part is the anchorage part, this part is the pulling part. People have tried U, V, whatever, but the consensus in general is it should be either straight or little bit in an L shape. You can use it in the brow, you can use it either like this, which is V, or you can use it either like L shape, same principle. So this one, the lower part of it actually goes along the eyebrow. This area is coming out at the peak, so that your eyebrow, the peak of the eyebrow goes up. Or it could be at the lateral part of it. Similarly, in the nose, you can push it inside one way or another way. You can use it on the breast, you can use it on the bums. But these ones, as I said, you need a lot of threads, and cones is significantly expensive, right? So you have to be careful, right? We give the local anesthesia, we insert this thing. Where we insert over here, we insert it in the subcutaneous tissue, right? So this is in the subcutaneous tissue, and this is how we put it. There is a mark usually here about 5 millimeter. You go that mark straight vertically down, sorry, 5 or 1 centimeter. You go straight vertically down, then you turn almost in a right angle, and then you go in the subcutaneous tissue, you pass it, you pass the cones, you then pull it. Once it is pulled, now you're gonna do the repositioning of the fat. This is what you do. You reposition the fat. So when you are passing the cone, you are first making a hole with an 18 gauge needle. You are tunneling the initial 1 centimeter or so on either direction. Please do not mind my right hand. I should have, asked the cameraman to be more like this, but you will give an idea. This is for the cogs. So the previous ones, when I was passing the cogs, that was after I passed the cones. Now, you see, I've pulled it. I've tightened up these knots. Initially, they are slightly bit of, loose. When I pass it, see what I do. Now, this will tell me the same sort of plane, right? Let me go back, right? See, when I pass and I lift the needle, both sides, it is in the same plane. That is what you want. So if you're not in the same plane, you can gently retreat and go back. You can do in this thing, not with the cogs, because they get stuck. So this needle, when I'm passing this needle, I go, first I pull it, then I go vertically down. You will see that black spot goes in, comes out. Now when I come out from that thing, you see I lift it. See how it is in one plane. That is very important. So this is all in the subcutaneous tissue. Then what I'm doing is I'm pulling with one hand. I'm not pulling it all the way. With my right hand, I'm actually pushing the skin back. So that is how the cones will go in. See, that is constant pull. This finger is actually pushing the skin out. So I'm not pulling with the left hand. So if I'm passing like this, I'm not pulling like this. I'm holding it. I'm holding with my left hand, and I'm with my right finger. I'm actually pushing the skin in the opposite direction. That is very easy part. And this actually takes in my hands, if I'm doing 4 or 5 sort of cones, it actually takes 15-20 minutes to do the whole procedure, right? And all of you can do that thing in that time, provided you do enough. You come here, you do now, you listen to me, you go back, not do it, not the right thing. So if you want to do it, straight away go buy things, do it while your memory is fresh, right? And once, now this is where once I've passed, and see another thing, that comes the cap of the needle, and I'm pushing it into the cap so that I do not do any needle stick injury as well, right? And then I push it. See, I've pushed it. There is already skin being repositioned, right? What happens after the first day? You get the dimpling of that, right? When you get this dimpling, it could be something like this. Just before, you can see everything, neck is improved, everything, but there is a lot of dimpling. Even as severe as this goes away within 1 week to 2. Now, this will take shorter time to resolve because we are in a much deeper plane. So when we are a deeper plane, the skin on top can adjust itself easily, right? And then this is one of my patients. She was on warfarin, very heavy, wanted to have something done. The only thing I could do was cones just to improve on it. I did not want to do any fillers in it, right? Again, a patient had a facelift done few years back, about 20 years back, wanted to have a little definition of the jawline. This is where I can do with the cones. These are pure cones. You can redefine the the contour of that with this. Complications are really less than the cogs. Cog is more technically demanding than the cones, right? And then you have got minimal recovery time. You don't have to be really a surgeon to do it, and you can do different area. Now comes, in my opinion, and generally, we have to improve. Sure.
Sir, regarding the silver stock, so once you have taken off the needles and now you're pulling and pushing it back, would you pull the upper part first and then the lower, or
It doesn't matter. But generally, if you want to, you see,
I mean,
in principle, you first want to anchor yourself, and then you want to pull on the other side. So if I have to do something, I'll first anchor it. So anchorage would go first. So the top would go first, right? Sometimes you don't even have to touch that thing, right? You don't have to do that thing. You can just do the lower part of it. I've seen some people not doing the upper part, but where I generally do it. I do it for the reasons, my aim is two things. My aim is to reposition the fat. My aim is to pull the mobile part. So when the upper part I'm doing it, I'm repositioning the fat over here, and at the same time I'm pulling from this side. So I'm giving amount right over here at the apex of my cheek, so that I can redefine it without a filler, and then I can add on top of that. So the third one is this thing, PDO mesh. It's called Facelift soft. There are other products in it which is like more surgically demanding. The concept comes from this mesh, which is support, right? So when you see, as I said earlier, this mesh actually, how does it work? There is a tissue ingrowth in the mesh, and that gives it the strength. And if we see, it needs to have about a 1 millimeter of the study shows that if it is less than a millimeter mesh, then the fibrous tissue will bridge it. It will not go inside, it will just bridge it. On the other hand, if it is 1 millimeter or above, the tissue will grow through it. So minimum is, or optimal diameter is 1 millimeter in order to use the mesh. And this is how this mesh is at present. This is the more surgical oriented. This is presently of it. You can see the mesh and you can see the cogs in the middle of it. So that's called 3D mesh. I mean, you can give it any name, right? That's like, you are trying to sell something. So, but I'm more interested of what is the science behind it. So the science behind this mesh is the cogs, which you can see the barb tissue, it is holding whatever you are trying to fix, and the mesh is like pouring a cement into all the scaffolding or the beams or the steel that you put in. So this tissue or the cement is going in between that. And the important thing is that 74% of this is achieved within 2 weeks, which otherwise can take about 2 to 3 months. It can be used almost anywhere of the body. If we compare to other absorbable market, these results are slightly longer time. It should be slightly longer time. I've used it not for that long to understand how long it works in my hands, but the concept behind it is that it has got a thicker cord, it has got a thicker and stronger hold, so it should last. And according to them, the company says it lasts between 2 to 3 years. The Silhouette Soft is about 1 to 1.5 years, and the cogs is around 1 year. All other things are important. One of the important thing is that the cost is, the cones are very expensive. The cogs and mesh is somewhere, if I say cogs is not that expensive, so this becomes like a low middle sort of thing. The cost is low middle, not high, so you can easily do it. And it comes in the same thing, right? You have got this cannulas, and inside cannulas you have this mesh, just like other bidirectional ones. And how you place it, basically what you do is that you make a hole. It comes with the same thing. You have got this loop coming out with some cogs in it. You have got this sponge sort of thing which is holding it. Once you go inside, you push it further. Now this thing, this small little white stuff, it usually stays out, right? It doesn't go in. You can see that it is staying out, it's not going in, right? So this diagram is technically wrong. So once you have deployed the furthest part, you pull out. You can pull out completely. And if I show you the cross section area, so you have got 1 and 2 side by side, so it's like going like this. right? So it will hold that area. Now, you can either come out over here and you can cut it. You can do rethreading into the same cannula. If I would you, I would probably stop when I'm doing this thing. I will stop it with coming out. I'll stop it over here, just underneath the skin. Change the direction and redo it, right? So what I'm doing is that this time when I'm changing the direction, I am going in a different direction, right? So I am going in a different direction. I was initially in this one. Now I came out, went back in a different direction. And when I'm coming out, now there is still a little thread left behind. There is a still little thread left behind. So I put it over here. Now when I pull out, I leave it over there. So now all the thread is inside the skin. Why I don't want to rethread it? It's a foreign body. I'm using my gloves. I might have touched this area, that area. So I would try to avoid it. Okay, let's go back.
Like compared with the cogs, please, like when we do push the cog in and we take it out, the thread is left behind, right?
Right. You can do it same thing with the cogs as well. You are going in, you are coming out. In the cogs, what we see is you come out. You see a little cog over there, right? You don't pull on it. Mistake. Pulling on this cog. Mistake. Because your cogs is in this direction, right? It is holding the skin. If you pull it, it can technically break it as well, right? Number two, someone, if your direction is towards the middle, then you can pull it. If the direction is away, so you have to make sure if the direction is away, you cannot pull on it. So if the direction is towards the middle, you can pull on this one because it will let it come out and then it will hold it further. So now you cut it. In this one, what you do is that when you're coming out, you can put this thread back into the cannula. You can go into another direction. I've pulled out. I have pulled out. Now I am going back in, right? Pulled out. I am putting the thread with this finger. I am putting the thread into the cannula again. Now I am going back into the same hole. Now I am going in a different direction than the previous one. Once I was going like this, came out, rethread it, change my direction, go in, come out. Go in, go in, come out.
So how is it going to stay because initially when we are putting it in, this white sponge is keeping that which
That's already there. That's already there.
gone in, the white sponge is
Yeah.
gone back.
Okay.
So how is it going to?
So you're going to demonstrate
So
also.
when you are
Yes.
repairing,
Right. Okay. This sponge
is keeping for the first.
is keeping the first loop,
Yes.
so that when you go inside, that loop stays over there. That loop stays over there, right? But this sponge is already out there. This sponge is not there anymore, right? This sponge is already over here, out there. It has done its job. Its job is only for the comb, for the needle to go in, and then it stays out. It's just like your chauffeur. Open the door for you, you go in, chauffeur stays out. He closed the doors, right? You come out. Either you come out completely, you put this thread back into the cannula and you go back, or you don't come out. You stay over there inside. Instead of going inside, instead of coming totally out, you stay there, change your direction and go back in. So now you are protecting the threads to be exposed to external environments. Basically, you are reducing the chance of any infection, this biofilms or things like that making. So you are doing that thing. So what you do is that you do not thread this thing, you do not thread it, you basically do not come out, you just change the direction, go in, come out, you will leave it over there. Now see the cross sectional area over here. The bottom part is this one, the middle part is this one, the outer part, the last part, does not have the cogs, it just have the core thing. That is the last part of it. Now you leave all the threads inside, right? So it's simple, you can just pull it out and cut it, no problem.
Sir, so the purpose of this last technique you have just mentioned is to avoid the risk of infection and not to enhance the efficacy?
No, it is to enhance the efficacy.
Both the things.
Yes. You see, you can, by not coming out completely, I avoid the recannulation or re-threading into the cannula. That is where I avoid the biofilm or whatever. But deployment, the full deployment in it is to utilize the strength of every part of the thread to hold it over there, right? So it will give you that extra strength.
We don't have any thread outside?
No,
All the thread is inside. We are
all the thread is inside. All the thread is inside. You paid for the all thread, so why not to use the all the thread?
The idea is to create a mesh.
The idea of mesh is the more the thread inside, the more the area which will be holding it, right? So you just sort of do that thing, and this area, if this thing, this is holding, this part is holding, that part is holding, so it's bunching up, so that there is more bunching up, right? So you can do it with the same cogs as well. Instead of taking it out, you can simply put it back, right? Now again, improvement, the global aesthetic improvement scale. Now you see, this is a published article from the surgical result arch of aesthetic plastic surgery 2014. The conventional molding type barbed threads, they have shown, I'll go back, they have shown that number 5 is worse, number 4 is no change, number 3 is improved, number 2 is much improved, number 1 is very much improved. Subjective, but an objective analysis of subjective results. So what they say is that 28% had a GAIS score of 2, which is improved, which is much improved, right? Or just improved, right? 55 improved. GIS score 3 is 55%, 11% GS score 4, which is no change, and 6% was worse than before. That means nothing happened and it actually got worse, right? So if that means, okay,
I mean, some kind of side effect?
not side effect, but sometimes you have not put it correctly, right? So it might not, or maybe the perception is it has gone worse, right? Because initially the swelling and everything, and then you compare it, has gone worse or whatever, right? So you do not see, and sometimes the the lightning or whatever, but this is all subjective analysis, right? So if we put an objective term to the subjective analysis, in this ones we are doing 28 and 55 means 83% has got improved or very improved. Now when we go to this mesh one, the statistic shows that 29%, over here was 28% with GAS score 2, here it is 29%, but with the GAS score of 1, which is much improved, right? Very much improved. 62% is 2, which is much improved, and 6% is 3, 2% is 4, no improvement, and 1%, less than 1% is that. So now we are talking about almost 97% of it is from improved to very much improved. So we have gone from 83% to 97%. So yes, it will help me. It will help my results. It will help me to have a better results than any one of you if I don't teach you this thing, right? Because before you start doing it, before somebody can come and start teaching you, I will have an edge of about 3, 4, 5 years. So these are much stronger lift. Even a heavy face can have an improved looks. Now this one was giving me, will give me better results, and this technique will now replace my dual plane thread lift. My dual plane thread lift was basically for the skin, I was using the cogs. For this deep tissue, I was using the cones. So I was pulling it like this. Now with one thing, I'm actually pulling both of them because it's helping me in both directions, right? Yes, yes, but you are going slightly bit deeper than the cogs, the conventional cogs. You are slightly bit deeper.
Slightly above the silhouette.
You are actually in the same plane as silhouette, maybe just a little bit, right? You see, I'll just show you in the beginning. With this thing, you can actually have a more stronger cache to all those true and false ligaments, because now the cogs, the cones will be difficult for them to really pull on, because there are 1, 2, 3, 4 cones, right? So if if one cone is here, the other cone is here, and you have got this ligament in between, it can't pull that ligament. The cogs is too small to hold on to that thing. This one is strong enough to hold the whole ligament with that tissue going through the mesh. So it will help you. It will help you with the skin. It will help you with the fat, and above all, it will help you with the ligaments. And it is, in my opinion, I don't have, it is my anecdotal finding or anecdotal observation, that it is because of these ligaments I am getting a better pull.
So when you are doing both the cogs and the silhouette together, which one would you put first? The silhouette?
The silhouette first.
So the fat and
Right. First I'll do the sheet, then I'll do the bed cover. Right. So in this thing again, you see, this is the area for the cogs. Usually subdermal means you are still in the subcutaneous tissue, but you are in the upper layer of the subcutaneous tissue. The cogs is in the middle or slightly bit lower of the subcutaneous tissue. This mesh is somewhere in this area, either between that or even in that area, right? So you are pulling, so this is like both of them. So this was like the cogs, this is like the cones, this is the skin, this is the subcutaneous tissue, this is the fascia. So what you were doing is that you are putting the cones above the fascia into the this fat subcutaneous tissue. You are just touching the underside of the dermis so that it catches up on certain parts of the dermis and hold on to it. The other one can be placed either at the same level as the cones or somewhere in between, depending on how thin is the skin. You want to give a little cushion to the skin so that you can't feel the cogs or the mesh or the fibrous tissue that it will make. So that is where your judgment comes. And when I was marking, you see, I was marking in a way, sorry, you know, now this is what happens. Sorry, let me just go back. We'll do the marking. Yeah. So basically this is where I'm putting the one part. You see, I'm just going at the edge of the jowls, marionette, and the nasolabial, right? So once I do that thing, where I want to pull, I will put like this, and there comes the dot. This dotted line is the cogs, right? This dotted line is the cogs, and after doing the face, I'm going towards the neck part of it, right? So the jowls and the face is done. Okay, this one is the loop ones. Just ignore this thing. It's more of a surgical. And you know, my patients, they had a good result, but you know, it was a little painful for them, and some of them don't need any cuts whatsoever. So you know, you have to keep on evolving. Once that is, now this comes, here comes the neck, that is along the jawline. Usually I'm not that fast.
Sir, excuse me, neck. How do you determine this?
Anywhere, you know, once you cross the sternocleidomastoid, that's less mobile. This is more mobile. So you want to go from lesser mobile to a more mobile area. You can actually go from the midline to outside as well. You can do whatever you want.
Behind this,
Usually either behind or over the sternocleidomastoid when you are trying to do it, right? Now this is how you mark it. So let's see. This dot is for the jawline and the cone. This dot, big dot, is for the cones. This big dot is for the cones. So one is mid face, one is zygomatic area, one is the jawline. Then comes the cogs, right? The upper one more horizontally, the lower one more vertically oriented. Then comes the lower one for the neck in more of a horizontal or oblique plane.
For marionette line for cones, you would stop before the line, and for the cones, you would go past the line.
You can actually do both.
So because we would like the cone to anchor the,
Yes.
the fat, so it has to go past
Yes,
that.
you see.
For the cone, we don't want to.
Yes, but at the same time, one of the problems that I've faced is because of the space involved between the cones. If I go between the, let's say my one cone and the other cone is, one cone passes the marionette, the other cone is that, I sometimes do not get that improvement. So what I do is that I just stop before that thing, so that when I'm pulling it, the marionette line gets.
No, I'm talking about the exit point.
That's what I'm saying. So if my marionette line is here, I'll stop it just before that, because when I transfer that fat, I'll improve that thing. If I pass that thing, I might not be really able to, you know, pull that much of cone.
Extra thread about 1.5.
Yeah, but you see, your marionette line, you over here, if you pass the cone, pass the marionette line, and you're mobiling it, your cone will come out of the skin, because you can't place your exit about another 2 centimeters from marionette line. You will come over here. So generally principle is I will just stop short of that. No, cogs are different. Cogs are different. Acha, theek hai. 2 minutes. Cogs are different. Cogs you can pass through that, because cogs is from entry to exit. And then you can see the improvement, the jawline, the neck, everything is there. You can actually see the marionette lines, how it is improved. You can see all the negative vectors has improved. This is what it was giving me in dual plane thread lift. This is what it was giving me in the neck and everything. See the marionette line, see all these negative vectors which has been improved. There is no fillers, there is no nothing, just simple dual plane. Thank you.
How often a person should repeat this procedure since it's invasive?
When you feel that you need it. Aesthetics is about how the patient feels. If I want something, if I want to wear,
Many times as she.
yes, as many times as she wants. But mind you, it is on an average 1.5 years to 2 years, and when you are doing both ones, the cost becomes very high. On an average, if I'm doing dual threads, I'm on an average charging 2,50,000 rupees, because almost 1,50,000 or 1,80,000 is my cost, or 2 lakh is my cost. So my cost goes very high. I'm using 2 boxes of cogs, 8 pairs, 4 up and 4 air. That gives you about 70,000 rupees. Then I'm putting 3 to 4 pairs of cones, which is about 1,60,000-70,000. So just imagine where my cost is going, minus the overheads.
So it means that patients should better go for facelift.
No. A patient for a facelift, and he or she is agreeing on the facelift, they don't need cones and cogs. They are facelift. This procedure is for the people who don't want to go under knife. The knife has got a downtime of 6 weeks, minimum 3 weeks. This has got a downtime of about hardly 5 days, 7 days, 8 days, right? we're going to start with the dual cone. All of you should stay here because everything would be shown over here, right? All of you, if you go there, you won't be able to really see it over there.
Explain about the safety planes for the entry and the exit. Safety planes.
Safety?
Planes.
It's subcutaneous tissue.
For the exit, there is nothing that you can't do beyond this.
Well, you see, if you go beyond nasolabial fold over here, you will disturb the lip. You don't want to disturb the lip. So if you're doing the cogs or the cones, cones will generally, in my hands, will stop just before that. Cogs will generally just pass this line, just pass this line.
For the
Entry, you know, you can do anywhere. The cones will go from the angle where I'm changing or the middle part where I want to put the maximum of the what you call it, this mobilization of the fat. So if I want to mobilize over here, it will go right on this point, which is in the intersection of this area, right at the apex. So there is no hard and fast. No. Change colors. Sorry?
Like for beginners.
Yes.
I don't know about putting the names. So can you only use one technique, like putting in the colors?
Yeah, start with one thing. You see, this dual plane is little advanced. You see, let's put it like this. I'm the one who has came up with this idea, because what happens in the world, most of the doctors are paid by the company. So there are certain doctors who are promoting cones. There are certain doctors who are promoting or being paid for the cogs. So they will only talk about cogs and the other person will only talk about cones. And in the panel, you will see this fight between the cones and the cogs. Right? It's like fight between a husband and a wife. But actually you need to understand, if they join hands, your car runs much smoother. So they are like helping each other rather than fighting with each other, right? So because I had no conflict of interest with any of the company, I brought them together. I published it, and this time in one of these conferences, Pierre and Solomondes, all of them, they actually brought the idea of working together because of this dual plane thread lift. Right. So Zara and